Good afternoon and welcome, everyone. My name is Chris Fox. I am Senior Vice President of External Affairs at the American Diabetes Association, and I am proud to welcome you to this afternoon's webinar entitled Understanding the Risks and Warning Signs of Diabetes-Related Amputations. To level set, I'd like to share a couple potentially sobering statistics for you. In the last year, there were over 154,000 diabetes-related amputations that took place in the United States. 85% of these procedures are preventable through earlier care, better diagnostics, and earlier interventions. Unfortunately, those individuals who are more likely to suffer from a diabetes-related amputations disproportionately come from communities of color. In fact, Black Americans are up to 4 times more likely to suffer diabetes-related amputation than non-Hispanic white Americans. Latinx communities and indigenous populations similarly experience rates of diabetes-related complications that are much higher than those from non-Hispanic white American. Additionally, 5-year mortality data show us that roughly 50% of those who have undergone a major amputation unfortunately do not make it 5 years after those procedures. And so because of this, this is the very definition of a health inequity, and where there is a challenge to be addressed, the ADA stands ready to answer that challenge. And that's why in September of 2022, we launched what we're calling our Amputation Prevention Alliance. The Amputation Prevention Alliance is tasked with addressing these rising rates of amputations that have taken place over the last decade and improving care for those who may be at risk for suffering a diabetes-related amputation, getting them the care sooner and better care from qualified folks. And we're here today to hear from some experts who can help us understand exactly what to watch out for, when to seek care, and what options you might have after receiving care. So with that, I'm going to introduce my distinguished panel of folks who are with us today. And first up, I will introduce Dr. Feluso Faccarete, who is the Chief Executive Officer at Cardiovascular Solutions of Central Mississippi and Fusion Vascular Center. Dr. Faccarete received his medical degree from Rutgers Robert Wood Johnson Medical School. He completed residency in internal medicine at New York Presbyterian Weill Cornell Hospital. Dr. Faccarete completed his fellowship in cardiology, interventional cardiology, and endovascular intervention at Cooper University Hospital in Camden, New Jersey. Dr. Faccarete moved to the Mississippi Delta in 2015 with a mission to educate and provide timely quality care to reduce unnecessary amputations. In this regard, he has decreased major amputation rates by 88% over a 4-year period, published in Cath Lab Digest, and has become the nation's leading advocate for PAD in the fight on the impact of PAD-related preventable amputations, with the purpose to bring equitable care to the lives and livelihoods of those impacted by this virulent amputation epidemic. Dr. Faccarete has been at the helm of working with congressional lawmakers on the Amputation Reduction and Compassion Act, which was included in the Health Equity and Accountability Act. His accomplishments have been highlighted in the ProPublica article entitled The Black American Amputation Epidemic that reached over 160 million people and has aired and been published on CBS News, NBC Nightly News, Reader's Digest, Men's Health Magazine, MedPage Today, and Apple News. Thank you for being with us, Dr. Faccarete. Also joining us here today is Dr. David Alper. Dr. Alper is a podiatric physician, recently retired from working in the private solo practice he started 36 years ago in Belmont, Massachusetts. Specializing in preventative diabetic foot care, he is now emeritus surgical staff at Mount Auburn Hospital, a Harvard teaching hospital. He currently is a member of the leadership board of the American Diabetes Association in New England, having served as president for over 20 years, and is an elected member of the board of trustees of the American Podiatric Medical Association. He also had the honor of serving as chair of the Belmont Board of Health for 30 years, where he was seen as a leader in public health for the community. This led to his being appointed by the governor to his current position on the Massachusetts Association of Health Boards, allowing him to continue his public health work. Since his retirement, Dr. Alper spent much of his time in the world of limb amputation prevention, using his connections in the diabetes, podiatry, and vascular worlds to create collaborations between medical societies. Dr. Alper is a noted speaker and writer on a variety of podiatric topics for the lay public, including articles published in Prevention, Health Journal, and Walking magazines, as well as various webinars and podcasts. When not in the world of feet, you can find him in the Blacksmith's Forge with his wife Pam and 3 wonderful children, Megan, Adam, and Brian, and his equally wonderful Shih Tzu, Gizmo. Thank you, David, for being here with us.
It's absolutely my pleasure, Chris. Thank you for inviting me.
Of course. Also joining us, Dr. Sarah Shelper. Dr. Sarah Shelper has always been passionate and excited about improving the lives of others. Even at a young age, Sarah knew she wanted to help others for, for a living by entering the medical field, but didn't know in what capacity. Driven by an eagerness to learn, Sarah started working at the age of 15 to earn a vehicle so she could travel to high school. Sarah's drive continued in college as she worked in Eastern Kentucky University's food court to pay for tuition. During her time at EKU, Sarah entered the pre-medicine track and realized she wanted to take a different path. Following her passion for helping others, she decided to focus on nursing so she could be at the bedside and positively impact patients when they were most vulnerable. After earning a nursing degree from EKU, Sarah began her adventure as a nurse at the Cleveland Clinic in one of the CV ICUs. After 3 years, Sarah moved to West Michigan and began her career in cardiovascular medicine, working in a cardiovascular lab. During this role, she was able to impact patients' lives directly through assisting with procedures to reopen necessary vessels to the heart and legs. But she knew she wanted to be more involved and build stronger relationships with her patients. As a result, she went back to school and earned a DNP from Grand Valley State University. Sarah joined ACV Centers to help shine a brighter light on peripheral artery disease, or PAD, a disease that goes untreated far too often and that we'll hear a lot about here this afternoon. She respects her patients and understands many of them have been told there's nothing more to do, and amputation is the only solution. However, Sarah and the ACV team work tirelessly to improve quality of limb and life and ensure amputation does not occur. With that, that is our panel here today, and I'm going to start by asking everybody on the panel a simple level setting question that I hope can get us started. And I hope that each and every one of you can feel free to weigh in. So I mentioned during the introductions that there are approximately 154,000 diabetes-related amputations that take place every year. What I didn't mention is that this is an increase of over 75% in just 10 short years. So my first question, and I hope everyone will chime in here, is how did we get here? What led us to where we are today? If it's okay, I'll just go in order here. So Fluso, you mind chiming in first?
Sure. First of all, just thank you for having me, and thank you for my esteemed colleagues who are here to shed light on this chronic, deadly, and most debilitating epidemic of all the cardiovascular diseases that has gone ignored for decades. I think number one is that the peripheral arterial disease is the narrowing of the blood vessels beyond just your heart that goes to your lower extremities, upper extremities. And that's due to the buildup of plaque and cholesterol. And one of the major risk factors is diabetes. So what has led to this point where the complication of it not only being not diagnosed early on, but the fact that this is a chronic and progressive and silent disease is that we tend to address it at the latter stages when we see it. Well, it's an invisible condition. Most people do not understand the correlation at first between diabetes and amputation until they're offered that amputation for a strategy. So for decades, we've ignored in our medical communities in terms of teaching peripheral arterial disease in our medical schools, in our nursing schools, in terms of the curriculum. It's been ignored. Number two, we've failed to address the social determinants of health that has perpetuated the epidemic of diabetes for decades. Number three, there's a lack of not only patient, community, but provider education as to what the preventative strategies are upstream, but also lack of screening, upstream screening of these patients who are at risk for this disease. So a combination of all these things, in addition to, different other mechanisms that have led to structural inequities in care in our healthcare system, is what you see as the amputation epidemic today. And unfortunately, we're still trying to play catch up. And we need to realize that this epidemic does not end at the belly button when it comes to the peripheral arterial disease syndrome. This can lead to a heart attack. It can lead to a stroke. It can lead to early death. And so until we as a medical community start talking about this as a constellation, as a family of syndromes, that's when we start really addressing the underpinnings of this epidemic.
Thank you. Thank you for that. David, thoughts?
Well, of course, I agree with everything my colleague says to start with. Two additional things that I feel feeds to this uptick, Chris, and it's really what's going on in our society today, because number one, the increase overlaps the presence of COVID over the last 3 years. COVID meant that people were not going to the doctor. And these are the very people that needed to get to the doctor. So for folks that had PAD brewing, and as we know, almost 40% of people with PAD are asymptomatic, so they don't even know if it's coming. So if you're not going to the doctor and having it looked at, if you're not getting it discovered early, by the time people felt comfortable returning to their doctors, by the time the doctors were allowing people to come in again, you had a crescendo of symptoms suddenly happening. The second thing is the overworking of hospitals and physician offices. So Feluso is absolutely correct. The medical community is not as knowledgeable about what's available nowadays. Part of the reason is doctors are so overwhelmed, they're not taking the time to learn. So 10 years ago, you could not snake a wire down past the ankle into the foot. Nowadays, it's common knowledge. So back then, a simple ABI exam, an ankle brachial index, which could be done by anybody, was the gold standard. I would maintain, and many of us do, that this no longer is the gold standard. We need to be doing angiograms to look and see if people at risk. But a lot of physicians don't know that nowadays because they're having to deal with overwhelmed offices, and hospitals are grossly overwhelmed and understaffed. And so who suffers because of this? Patients at the early stages of disease that wind up showing up at the later stage in disease because they put off their examinations. And when they're finally trying to get in, they're being put off to be put in more. It is why it is so vitally important that people own their disease and start doing self-examinations at home and reacting to it as quickly as possible. And hopefully we'll have a chance to talk about instructing folks how to do that. But by being able to be part of the diagnosis and care of yourself, this is one of the tools that I believe strongly is going to be able to prevent this continued uptick that you mentioned.
Thank you, David. Sarah, would you like to offer your thoughts?
Yes, I would have to agree with everything that was just mentioned, and thank you all for having me here. I have to emphasize on my perspective that there is a lack of education, not only with patients and themselves, but also on providers. Getting the providers to understand what is the first sign and symptom that we're looking for. How does it present? It's not always black and white. It's very, very gray. And knowing how to examine a patient appropriately and getting the testing necessary can allow us to not only intervene quicker, but also be proactive versus reactive. And then our patients to understand and spread the knowledge of what is PAD and how did they take a step in all of this, and understand what kind of resources they have in their area and who they can go to for help. I think those are all valid points as well.
Thank you. Thank you. There seems to be a common theme here a little bit in the early comments here about the timing to seek care. David, as a retired podiatrist, weigh in here on at what point should a patient, or in particular a person with diabetes, seek out care? Should it be, when something goes on? Should it be regularly? Should they wait until there's some sort of other condition, neuropathy or pain? At what point should a patient seek out some specialized care?
Well, the short answer is that just like you have an ophthalmologist when you are diagnosed with diabetes and go for your yearly eye exams, you should at a minimum be going for an annual foot exam, because obviously early intervention is the key to preventing amputation. The second thing is that you need to be reactive, and you don't want to be reactive when one of your bones is sticking out of your foot. You have an area of redness, you have a change in sensation, you have a loss of sensation. These are all early hallmark signs. And once again, so much of PAD changes are asymptomatic, but things can be seen visually. There's a very, very simple, what we call the 3-minute foot exam that any layperson can do. And it's really 3 simple things you need to check. You need to look and see whether or not you have a temperature difference between your legs, or if there's a temperature cooling from your knee down to your feet. And simply running the back of your hand down your shin can tell you this. And if you don't feel comfortable doing it, having someone do it for you, actually usually better. The second thing is if you notice that the hair has stopped growing on the lower part of your legs. The grass doesn't grow when you don't water it. And if hair stops growing, it's not being stimulated by your circulation. And that is a sign of beginnings of possible changes in your circulation. And the third thing is to take your big toe and simply push the end of it until it blanches, until it turns white, and let go. If that toe does not turn red again in 3 seconds or less, you may be seeing beginning changes of the tiny circulation within your toes. And this again is a change that is worth bringing to your doctor. At the real end of the day, Chris, I'd rather people go to the doctor with nothing than not go with something. And that may sound trite, but it's these simple changes. The other thing, and then I'll certainly let the others chime in, is any area of redness on your foot, any area that may be rubbing, any area that may be feeling excessive pressure, especially if you're experiencing diabetic neuropathy, if you're experiencing numbness within your feet. These reddened areas can easily break down. And it's a whole lot easier to help something that's red than hit something that's a hole in your foot. So the short answer to your question is, if there's a change, that's a reason to have somebody that knows what they're talking about take a look at it.
Thank you.
I'll add to that. I think when patients do present to their primary care doctors, or if they start eliciting symptoms of neuropathy, retinopathy, and also if they have any signs of nephropathy, what we call microvascular dysfunction or microvascular symptoms, those are early signs that actually can predispose you not only to peripheral arterial disease, but unfortunately, some of these patients are at higher risk of an amputation if not caught early, to David's point. And number two, anyone who's at risk for peripheral arterial disease, for instance, anyone under the age of 50 with a history of diabetes and one additional risk factor, namely nicotine use, hypertension, high blood pressure, high cholesterol, a family history of peripheral arterial disease, or anyone who's had a stroke, heart attack, or anyone who's had any other major atherosclerotic disease or plaque buildup in any of their major arteries, or anyone who's a Medicare recipient, right? Anyone over a certain age. These are all patients who are at risk for peripheral arterial disease. And so at some point when you go see your primary care doctor, you should tell them, like, hey, listen, take off my socks and check my feet, to David's point in terms of that exam, but also check my pulses and just make sure that there is nothing abnormal. There are simple non-invasive tests that can be done both in the office setting that can help them, elicit if they're in the early stages. And then they can start eliciting the appropriate medical therapy or supervised exercise testing, whatever therapies that are needed upstream before we start capturing these patients with gangrenous foot and non-healing ulcers that have gone on for weeks. And we call this critical limb ischemia or critical threatening limb ischemia. Those are the things that we're trying to prevent, because you read those awful statistics that lead to major adverse limb loss and also major adverse cardiovascular events such as stroke, heart attack, deaths. Those are the statistics we're trying to avoid, right? And majority of these patients who get to that point are not offered a limb preserving strategy. They're offered an amputation first strategy. And unfortunately, if you're a diabetic and you undergo a major amputation in this country, 80% of them are dead within 5 years of that major amputation. That is devastating to not only the patient, the family, but for those who talk about, someone who is functional in community, functional to the job space, functional to, to the community from a different standpoint, absenteeism at work, our health economy, cost. Those are all devastating across the board, clinically, economically, and from a human standpoint. So those are all important factors that we need to consider.
And let me, if I may, add one thing to what Faluso said. It is absolutely true that the physician should be checking the pulses on your feet, but patients, do not just assume you have good pulses means you don't have PAD. I like to use a pasta analogy, that the pulse that you feel on the top of your foot is a blood vessel about the size of linguine. But the blood vessels in your toes, you're dealing with angel hair pasta. And just because the blood's getting down to the top of your foot past your ankle does not mean you don't have peripheral vascular disease, changes within the small blood vessels in your toes. It's why you need to have the full, and it's literally 3-minute diabetic foot exam. And having a podiatrist included in your life, having your primary physician get those socks off and do a full exam of your feet every time you're in the office is going to do a lot more than, Mrs. Jones, your pulses are fine, don't worry about it. And this happens just all too often.
I would have to add to that. I can't emphasize the important part of just take off your shoes and socks. That does a slew of things for providers. You can see what the foot looks like. You can feel what the temperature is. That's step one. Step two is making sure that the patients aren't dismissive to their symptoms as well, thinking that, oh, I've had neuropathy for years, this is normal for me. Well, it may not be normal. And how do you know it's truly neuropathic pain versus ischemic pain? And making sure that they're also aware to their body and their symptoms and getting proactive therapy as well.
Great. We've talked a lot already here today, but maybe it would help to level set the conversation a little bit. So you said earlier that PAD can be, in some cases, an invisible condition for some time. Can we just level set a little bit? And can you help us maybe with Sarah and David? Let's understand what PAD is and understand who's at risk, what some risk signs might be. I know we've talked about neuropathy, we've talked about pain and things like that, but let's talk a little bit about what PAD is so that we can all understand exactly what we're talking about.
Yeah, PAD is a circulatory deficiency where there's a narrowing of blood flow to your lower extremities or upper extremities. It doesn't just occur in the feet, it can occur in the upper extremities. And once that happens, that leads to certain symptoms. And those symptoms can be atypical in nature, meaning some people can just have that inability to ambulate as longer distances than they usually do. Or some people can have pain both at rest or with exertion. Some people have them with exertion that go away at rest. But unfortunately, as everyone has stated on this panel, majority of symptoms actually are asymptomatic. Patients just don't know. About 40 to 50% of these patients do not elicit your classic symptoms that we're taught in our textbooks. So here's what happens, because we're taught that claudication, and this is a term that's thrown out there, is the primary pathognomonic sign for peripheral arterial disease. That is correct. However, only 15% of patients with peripheral arterial disease present with claudication, meaning I walk to the end of the hall, I have pain, and at rest, it goes away. Majority of my patients who I see here in the Delta who are diabetics, they live in the diabetes belt of America, actually don't present with those type of symptoms. And so that is something that we have to understand as both in the medical community and non-medical community. It's like cancer. It's slow, it's progressive, and it's deadly. And so that's why screening these patients upstream is important. Two, if left unchecked, it can lead to a non-healing wound, an ulcer, or gangrene, that kind of black and darkened foot that you hear about and you see, particularly after a 2-week period. That's the technical term for CLI or CLTI that's being thrown out there, critical limb ischemia. It's basically an end stage of peripheral arterial disease. And when it gets to that stage, unfortunately, a lot of folks think that the primary treatment strategy for most of these patients who have non-healing wound and ulcer should be an amputation. And that is not the case. There are a lot of things that can be done upstream immediately that from a diagnostic and treatment standpoint to aggressively treat these patients. Unfortunately, we live in a medical healthcare community where a lot of patients do not have access to doctors who are on this panel today. Some live in vascular deserts, medical deserts. They might have a podiatrist, but not have an interventional proceduralist to do that limb preserving or unclog those arteries. And we know that unclogging those arteries and restoring blood circulation will decrease the odds of an amputation by 90%. Well, 90% of the major amputees that I've seen in this region in Mississippi have not been offered that until we got here and started preaching to the community and engaging the community and talking about what a second opinion looks like and what those results can be. And who's at risk? It's a lot of people. Well, number one, if you are, again, between the ages of 50 to 69 and you've had either nicotine use or diabetes, you should be screened. If you're less than 50 with one additional cardiovascular risk factor that I mentioned earlier, you should be screened. If you're a Medicare patient over the age of 70, you should have basically a study to look at your circulatory function. If you're a minority, that is actually a risk factor because irrespective of your social determinants, that is something that we found in certain patients that increases their risk of an amputation. And then if you've ever had a heart condition that required a stent or a stroke or TIA, you should have your circulation in your feet looked at as well. And then if you're an end-stage renal disease patient with chronic kidney disease, that's another additional risk factor that you should look into.
See, and once again, Chris, it also is the subtle changes that you can be seeing yourself. I mean, everything that Faluso said is 100% correct. And if you've been dealing with other medical conditions within your body, or if you just have a bad habit like smoking, or if you have, an unfortunate condition like diabetes, yes, you're at risk. But if you're noticing things like you're not growing hair on your legs anymore, that should be ringing a bell. And it may not sound deeply medical, but these things don't happen in a vacuum. There's something going on. And that is an early opportunity to do this. It is so vital for people, especially folks with diabetes, to be self-advocating. to be making sure that they're getting every opportunity they can to keep themselves healthy, whether it's the foot exams, as Sarah had mentioned, of getting those shoes and socks off, of looking themselves to make sure that the changes are not being missed and that they're reacting accordingly to it, to upticking your lifestyle a little bit. I mean, smoking and PAD, I mean, there isn't even a conversation that should be going on with that. But, you know, to Faluso's point, the Black community is 25% less likely to get vascular intervention when it's needed. And again, the statistic that I hang on so much, you started off with, Chris, 85% of these amputations are preventable. That's horrifying that this is going on in this country today. So it is the job of the medical community to continue to educate themselves of what exactly is out there. It is your job as the patient, as the potential patient, to make sure you're getting everything you need, but also to be monitoring yourself. You see an area of your foot that is red and it wasn't red before, or if you can't see your feet anymore, or you can't reach your feet anymore, you get a loved one to do it, and you see a red spot, that is a sign to get into somebody that knows what they're looking at. And this is where you're really going to be able to make a difference in the horrors that PAD can offer.
Thank you. You know, we've talked a lot about PAD. I'd like to talk a little bit also about diabetic foot ulcers and what they look like and who might be at risk for them, and at what point they might be able to start being concerned about this. So, Sarah, David, I'm wondering if you can weigh in, you know, about the role of non-healing wounds plays in amputation prevention. Sarah, can we start with you on this one?
Yeah, I don't think there's any such thing as too early. I think the moment that you realize that you have a sore spot, even if it's a small opening or not even open at all, and you're a diabetic, you have to get treatment, you have to get evaluated urgently, because all too often do we see that that little spot becomes a huge wound. It's now gangrenous, and that's when people are being told they have to get an amputation. And a thing I need to emphasize is if you are being told you need to get an amputation, you need to say no. You need to take that upon yourself and you need to get a second opinion, because as we've been discussing, there is 85% of these patients, it was unnecessary. There's things that can be done to prevent that. So if you notice anything with your legs or your feet and it's changing, just get evaluated. It's better to be safe than it is to be sorry.
Thank you.
And I will be happy to add to what Sarah said. Number one, angiograms. Somebody comes at you and mentions an amputation without an angiogram, that borders on malpractice to me nowadays. So you need to advocate for that. The second thing is, this is a world of second opinions. And there is nothing insulting to a physician to ask for a second opinion. And I would maintain if a doctor pushes back against it, that's a doctor to run away from. So those are two tools you have right there. Diabetic ulcerations, Chris, are just that. It is a hole that develops in our skin, usually from excessive pressure and friction, though very often it could simply come from a breakdown of circulation. It is why the most mundane things in my world of practice, making sure that shoes fit properly, making sure that the quality of the shoe is there, is vitally important. More than half the people that come into my office are wearing the shoes that are just too small. You know, Dr. Alper, I've been a size 8 my whole life. Well, guess what? You haven't. You're a size 10 now. And if you have a little bit of neuropathy, or if you're just distracted through your life, you're going to wear shoes that don't fit properly. And that constant rubbing, and then you have the presence of neuropathy where you don't feel the rubbing, is what's going to break it down. Ulcerations come from excessive pressure and friction in an isolated area of the foot. And in someone with normal circulation and normal feeling, first of all, you'll feel it before it breaks down and you'll stop letting it rub, and the circulation will try to maintain it. So at worst, you may get a little blister. In people that are compromised, that tissue cannot continually repair itself from chronic irritation, and the skin just gives up and breaks down. And once it breaks down, we on the outside need to help it heal up again. And if the circulation is not there, then the building blocks that make that wound heal are not going to get down there. The hole is going to go deeper and deeper until the bone is exposed, until gangrene sets in, and that's the course that leads to an amputation. The simplest thing to do right off the bat is, as Sarah says, early and often. You see a red spot, you see a blister, you see a tiny hole, you run thee to a doctor immediately to have that looked at. You make sure that your footwear fits you properly. And that's something that should be checked regularly. Unfortunately, when you go shoe shopping nowadays, it's not the kindly old man that sat on the box in front of you. So you need to make sure you check it yourself, that there's room between the end of your toes and the end of the shoe, that you're not straining the laces. You don't want to hear, don't worry, the shoe will break down, it'll fit properly. No, it won't. You don't want to use your foot to break down a shoe. So it's a combination of taking away the causes of these ulcerations, which is the irritation from the outside, and addressing the things that are causing the irritation. And then, as Sarah says, early intervention to keep it from becoming a bigger problem.
I think it's important to also emphasize not only wearing proper fitting shoes, but also protecting your feet from injury and knowing, hey, pay attention to where you're walking. What are you walking on? Put something on your foot. You don't need to go barefoot. And checking your feet and in between your toes every single day. And if you cannot do that, find somebody who can. Good proactive measures as well.
Yeah, and care coordination is very important in this context. I mean, we talk about the things we need to do to intervene, but remember, these are patients who, some of them are, in terms of their health literacy status, in terms of understanding not only the impact of diabetes if it's not managed appropriately, but also the steps that they can take from a lifestyle and dietary modification standpoint to help their wounds heal. Because it's not just I get the angiogram and my life is set, or I get that medication that we prescribe and that's it. This is a lifelong process, but this is also a process that needs their aggressive intervention in terms of lifestyle changes, knowing what a worsening glycemic or sugar control will do to that wound is to make it not heal. Making sure that they know that upstream their hemoglobin A1C is something that should be downtrending, not uptrending. In the context, I don't care how technically competent we all are here, if that is not managed, that outcome is not great, because that also has a correlation in terms of the outcomes for severe ischemia, but also an amputation risk is very high in these patients with poor glycemic control. So we need to do a better job, not only from a medical standpoint, but the social determinants of health that play into why there's diabetes numbers are uptrending. If you look at the prevalence of diabetes in our country and where that's headed over the next couple of decades, it's only getting worse, and we're seeing it in younger patients. So we're actually doing a poor job in terms of managing these patients overall.
And it's a question about owning your disease, as I said earlier. You need to be asking questions. You need to be seeking information. Part of the problem that you alluded to, Faluso, is that we're dealing with cultural issues. When the dietary trends within a culture are based on plantains or based on rice or high carb diets or high fried diets. I mean, this is a problem that needs to be addressed. All too often, and I know the both of you have seen this as well, is you tell someone the unfortunate news that they have to have a toe or a foot amputated. And sometimes they look at you and say, well, now I'm going to look like grandpa or grandma, because they just believe this is the legacy of the family. They just accept it, that that's their destiny, because that's the way it's been through the family. You've got to break that. You've got to get them the information they need. You got to get them to the people that can help them, so that they don't just simply say, oh, well, this is what's happened in my family for generations. Of course, it's going to happen to me. The diabetes going through the generations is accepted. There's no reason that any other part of it should be. And culturally, very often it just is.
Thank you. And I thank those who are watching this event live and are putting some questions in the comments. I would encourage others, to the extent that you have questions and time allows, we will circle back to these. But for now, I want to talk a little bit about screening. We've all talked about, earlier intervention, earlier care, earlier diagnostics. We've talked about the need to do screening, but as we know, if we know that we need to do screening, why doesn't screening happen more often?
Well, I mentioned already time in the doctor's office. So let's start with that. The reality is that when you visit your PCP, your primary physician nowadays, they're there to treat acute things. They're not there to necessarily treat chronic things, because they just don't have time. It's a terrible thing, but it's a reality. So if you go in and you say, I've got this injury that's bleeding, they'll look at it. But are they going to take the time every time to take off your shoes and socks? They're probably not. Who hopefully is doing it is their support staff, the PA, the NP, the MA that's in the office. And the patient needs to if doctor doesn't take the socks off, they need to take them off themselves or ask them to be taken off. That's how screenings are going to happen, Chris, is to push for it a little bit, because time is such a precious commodity in that exam room. More and more within communities, you are seeing foot exams. The American Podiatric Medical Association does foot screenings throughout the country. My colleagues do them quite often. So that's another way of getting them. But again, I know on the ADA website, on the APMA website, I'm sure other websites, they show a basic 3-minute diabetic foot exam that can be performed by themselves. So I know I'm sounding redundant, but again, I'm putting some of this screening back on the patients themselves to make sure that if they're not able to get into the office to have it done, at least they're having it done within their homes.
I think we need to be cautious in terms of putting it just back on the patients, just as we have for cancer. We have a national screening guideline. The U.S. Preventive Service Task Force has come up with guidelines for everyone. I don't care what village or what country you're in the world, you have access to these guidelines, right? This is cancer screening that for anyone who's at risk. Because why? Because we know how deadly cancer can be. It's silent, it's progressive, it's costly, right? And it can be prevented if it's caught early. Well, this is a disease, peripheral arterial disease, especially in its worst stages, actually is more deadly than most cancers that most Americans have. Unfortunately, the same task force that came up with the cancer screening has not come up with one for peripheral arterial disease. And until we do so, we're going to keep on having this recurrent issue. There are people who think the doctors need to do better. Well, doctors cannot screen something that they're not taught of. In 4 years of medical school, I only had 2 questions about peripheral arterial disease on a national test. And that hasn't changed significantly in medical school curriculums. So, and not everyone has an access to a Dr. Fakarady or Dr. Alper. For instance, a state like Mississippi, where you have just how many podiatrists in the whole entire state, a state that is ranked high in diabetes, has only about 17 podiatrists and 7 endocrinologists in the whole state. So we have a problem that we need to size, scale, and we need to get real about. And until how we get real about it is to make sure that we have a national policy that makes it fair and just, whereby irrespective of your background, your race, your social determinants, that you have access, at least to be given a fighter's chance to live a healthy life where you can get screened early on and you can get access to equitable treatments upstream.
We have to talk about the role of screening and how do you screen, right? We know in the diabetic population, particularly an ABI is probably not going to give us the information that we need. And it may come back normal, it may come back abnormal, but truly these patients typically have tibial pedal disease. And at that point in time is when we really need to get an angiogram versus an ultrasound. Ultrasound's probably a better screening tool. It's less invasive. So we really have to also not only encourage screening tools, but also appropriate use of screening tools.
For sure. With this, I feel like I should interject a stat point. There was recently, the American Diabetes Association conducted a survey of 3,500 Americans living with diabetes. And on that survey, they asked them a number of questions about what they are doing to reduce their risk for suffering from an diabetes-related amputation. Included in that was we asked participants how many of them did regular self-foot exams. Would you be surprised that 81% of these respondents said that they did regular daily foot exams?
I would be.
Yeah,
I
like to know where these patients are from.
Yeah,
that's the number one question. So you need to tell us the demographics, which like where they are, and because that matters, and their educational status, right? Mm-hmm. And because that it's very important. Average patient of mine has a 5th grade literacy level, and a lot of them do not have that exposure to what it takes, as David, eloquently mentioned, what that 3-minute exam is. That's why community engagement is very important. I always tell doctors, gone are the days where we just sit in our clinics and in our comfort zones. We need to go out and preach that message. We need to go show them how to do it. And so it all depends on the exposure that those patients have had, Chris, the doctors they've had exposures to, and also their literacy level to be able to have access to tools and resources that has enabled them to be able to do so. But that is not the average patient that I see in my practice. I'll let Sarah and David go.
I was going to say, I would also like to know what their definition of a foot exam is. Are they actually looking underneath between their toes, or like, hey, I looked at my foot, when I put in my soccer
I,
on. What is the definition of a true foot exam?
Right.
I will join in with that. I practice in Massachusetts in a little tonier area than Volusia with, and let me tell you, these people are not looking at their feet. I mean, and the fact that half of them can't reach their feet is probably part of it as well too. Another problem, of course, that Volusia didn't mention is internet access. I'm sure there's a ton of people in your community that can't access the information that is all over the internet because it's just it's not something that's available in their lives. So we do need to find better ways of penetrating. We do need to have road shows, which are starting a little bit, setting up in senior centers, setting up in churches, setting up in community centers, where knowledgeable people can take a look and educate so that then they maybe can go home and do that. But I agree. I'd love to see the demographics of that 81%. That would be
for sure.
Breakdown.
In the spirit of surprises, there was a comment that was just posted here from a patient who said that he was never aware of what PAD was until he was diagnosed with PAD. Does this surprise you?
No,
No,
absolutely not.
no.
I think that emphasizes as to what we are here for and spreading not only the education of what PAD is, but how do we need the gap needs to be bridged, right? There is a discommunication between those who know what PAD is and the individuals who come in contact with the patients who have PAD that don't necessarily know what that means. And having someone in your team, for instance, at our team, we have nurse navigators who not only help us communicate and educate our patients about why it's important for you to come in. They triage the patients and they know when there's a sign of an early change, they get them in immediately for us to evaluate them. But not only that, they reach out to the primary care providers. They reach out to the wound care specialists. They talk to the podiatrist. They make sure that we're all on the same page to ensure not only proactive measures, but to help outcomes and help the quality of life of those patients. So I think somehow bridging the gap of how do we come together as a society to make it more efficacious for patients.
For sure.
Chris, it's interesting because ADA and the medical community decades ago did an amazing job of connecting diabetes and eye disease. And anybody who's diagnosed with diabetes is automatically given an ophthalmologist, is giving an annual eye exam. Insurance covers an annual eye exam. It's never questioned. We need to be able to repeat that for PAD and for foot exams as well, too, to make sure that insurance isn't an infinite and that the knowledge is out there that it's just as essential as that annual eye exam.
And also, we need to heighten awareness efforts. I mean, to that patient's credit and to what David and Sarah mentioned, I think the number one fundamental problem we have in our space is not just the word peripheral arterial disease, which is a mouthful, but number two is that we lack awareness. I mean, awareness on all levels. A lot of patients just don't know this disease. A lot of providers, unfortunately, are not well versed in terms of the full treatment, in terms of the algorithm of how to go step by step, not only in diagnosing and preventing, but also in treatment options that are available to certain patients. And some of them still opt for an amputation first strategy because that's all they've known. So just as we're passionate about, changing the generational scar and stopping this generational scar in these patients, we also need to talk about the gaps, not only in knowledge, but also in research, in resources, and in policy that has led to the fragmentation of this disease, and not only in not being able to upstream preventative strategies, but also in awareness and in treatment gaps that do exist.
For sure. Sarah, I want to ask a question here of you, and then I'm going to pivot to asking this panel some of the comments and questions we've gotten here. But Sarah, as somebody who sees patients regularly, can you just let us know, in terms of a day in the life of a patient with PAD or CLI, what does that patient's care journey look like?
Well, I have to start off by saying it's going to be lifelong. Many times a patient comes to me and unfortunately it's after maybe they already had an amputation that could have been prevented, with tears in their eyes looking at me, what do I do now? Well, I would love to say that we could cure this disease, but we can't. But what we can do is we can treat it. And knowing that you're going to need to stay with your vascular specialist and you're going to have one-on-one communication with any change immediately. And that could be, and you need to have weekly visits even with your podiatrist or your wound care specialist. So in the interim, when you have CLI, you have to expect that you're going to be seeing a doctor at least weekly for the goal of amputation prevention and improving your quality of life. But also, as that journey begins, the educational aspect from the provider to that patient. What can I expect? How can I prevent this from deteriorating? What other things do I need to do? I think those are also important with the risk factor and lifestyle modifications.
Great. Fluso, you want to weigh in there too?
Well, in terms of these patients, I mean, I would like to, just talk about, why this is so important is because a lot of the patients that some of us do see on a daily basis, unfortunately, are people who've had a minor or major amputation. And I hate to use the word minor because the minor amputation is any amputation below the ankle. And quite frankly, there's nothing like minor. I mean, limb loss is limb loss. No one should be losing their foot if 90% of these losses are preventable. That's number one. I mean, we have our technical terminology from a medical standpoint, but one toe versus two toes versus below the ankle or above the knee or below the knee. I mean, those are all catastrophic. I mean, it's a slow, strategic, debilitating loss that eventually leads to the end of life. And majority of the patients I saw initially in 2015 who had a major amputation are no longer with us. And so I continue to treat their family members, and you keep on hearing stories about how this costs that patient, not only from a economic standpoint, but a patient has to take another family member out of the workforce or workplace to bring them to their visits or to take care of them on a permanent basis. And the community suffers as a whole when this happens. And so community engagement is very important in terms of trying to make sure that these patients are, number one, trusting to the medical community, but two, that they engage early on so that we can give them the tools that they need in the toolbox to prevent a catastrophic outcome.
Sure.
Let me also put a ray of sunshine here, Chris, because the reality is that early intervention can lead to a very good result. Many of the ulcerations brought into mine and my colleagues' offices are healed, partially because of the work of Fluso and his colleagues, where they revascularize. Part of it, the work of my colleagues and the new techniques and the new materials that are available to get these ulcerations to heal. And if the ulceration is healed and the foot is revascularized, there is no reason for there to be an amputation. So, to Sarah's point, yes, PAD is a lifetime commitment, but it doesn't necessarily need to be a depressing lifetime commitment. There are things we can do to reverse the process that has started if we can get there early enough, that these ulcerations can be closed, that circulation can be returned to a foot, to an ankle, to a lower leg. And so thereby, these people can return to a normal life, can return to a full life, as long as we get in there early enough and the intervention is appropriate.
I think to add to that, it's important that when the patient comes to see you and you talk to them about expectations, that, yeah, our goal is we're going to get this wound to heal and we're going to prevent that amputation from occurring. The journey getting there can be long and it can be sometimes hard psychologically for the patient. But knowing that with a close communication and a close bond between the vascular specialist who's restoring the blood flow and the wound care specialist who's working from the outside to make sure it continues to heal, and that communication is also not broken, these things can heal and patients can go on to have a normal activity and normal quality of life once it does. And then taking from there, how do we prevent this from happening again? Where do we go from here? Type of thing.
Right. And that's exactly correct.
Mm-hmm.
We have invoked a couple times here the social determinants of health. Access to information has been brought up as a challenge, or potentially even an opportunity by increasing access to some of this information and raising awareness. Are there other ways that we can improve health outcomes for targeted populations, including by addressing some of these social determinants of health and in the process reducing the number of diabetes-related preventable amputations?
Yeah, I mean, number one, we need to address social determinants of health. I mean, we have not addressed social determinants of health in this country for decades, in spite of what the Institute of Medicine has said in the 80s. And this is something that is striking. A lot of people might not know this, but these factors, these social determinants, are things that have led, in spite of all the progresses we've made from a technological standpoint, pharmaceutical standpoint, technique standpoint in the cardiovascular space in over 20 years. We have not seen decreases in diabetes rates, in blindness, in dialysis rates, in amputations, and in major adverse cardiovascular deaths, in certain, especially minority populations, in over 20 years, in spite of all these advancements that we've had. So the question becomes, why have we failed to address social determinants? I mean, this is where it's bigger than just our medical hats. We need others in the room. It's where do the education inequities and economic inequities play? Where does structural racism play? Implicit biases? Where there's the housing and transportation issues that most of my patients plague in terms of inability to even walk, or have a sidewalk in their communities, or to have transportation to come and see a specialist, because most of them have to drive 2 hours to see a podiatrist. That matters. And so those are little things that we have to address before we really gain equitable care when it comes to cardiovascular outcomes in this country.
It means the government needs to be at the table. It means insurance companies need to be at the table, because these are the blockings of what's going on here. Back when I was in medical school in the 70s and 80s, the government would pay your tuition in exchange for you giving so many years to an underserviced area. And it was wonderful, because that placed podiatrists in Mississippi. It placed podiatrists in South Carolina. Why? Because they took care of their 4 or 5 year tuition bills, and so you were somewhat indentured to them for it. That program no longer exists enough to be able to place this in the way that it used to. This is just one of the things. Insurance companies still push back at paying for basic screening exams. It is absurd that in this day and age, the insurance companies are still reactive versus proactive in their coverage. So they don't bat an eye at paying the $50,000, $60,000, $80,000 for an amputation, but they push back on a $300 pair of diabetic space shoes or a $100 foot exam. These are the types of disparities that go across the country. And then you see where they settle into the zip codes, where you settle into the different minority communities. And we in the medical community can continue to talk about this, but until the government and the insurance companies recognize exactly what Feluso and Sarah have been saying of these disparities, it's not going to change. So we can come up with the best medications and treatments in the universe, and if you can't get them, it's not helping your life.
Right. And it's the care, it's the knowledge, it's the community support, it's education for the community. And then it's also the cultural buy-in that, like you said earlier, oh, my grandpa and grandma, they lost their toes. I figured I would too. Well, it doesn't have to be that way, and breaking that correlation as well. And yeah, it does start with policies and procedures, and how do we get from point A to point B without always having to go through all these loopholes so that our patients can finally get it is what they need. We should just be able to do that for them. They deserve it. Our patients' outcomes deserve it. We all deserve it. So we just need to figure out how to get there.
Great. So there is one last question here that I want to ask, or maybe two last questions here before we wrap up here. One question, and I think all of you have a unique perch here and would welcome your insights. If you're a person with diabetes and you're going to your annual doctor's visit for a physical or a checkup, what questions should you be asking of your doctor, of yourself, or of anybody else as you're seeking out your routine care? And specifically, what question should you be asked if you are diagnosed with PAD or referred for an amputation?
As I said earlier, I think that if you're referred for an amputation and this is your first initial encounter, you have to say no. You step away and you find somebody else, a vascular specialist you can go to get that second opinion. You should be asking to make sure, hey, have I gotten the screening tools? Have I gotten the ultrasound? Have you looked at my circulation before you tell me I need an amputation? Has everything really been done that needs to be done? As far as diabetes goes, making sure you're on the appropriate medical therapy. I mean, too many times patients come in and they're just not on what they need to be on. And there are multiple factors that go into that, right? Like finances and patients sometimes just don't want to do that. But asking your physician, is there a better medical regimen for me? Is my A1C going the way it should be? Types of things like that.
Great.
I tell my patients that their hemoglobin A1C, which is basically their medical passport, is something they need to have memorized. You need to know what those numbers are. And you need to know what you can do to have that number at a low value. I mean, we say less than 7, but that's something that we work with our patients, and two, we talk to them about diets that they need to be on, and then what are some of the challenges. You have to ask your question: what are the challenges you're facing at home, and how can we either work with our partners to get you those resources that can make you a better patient from that standpoint, and adherence, because it's not because they're non-compliant. I hate that term. A lot of them just have real life issues and real life challenges that we need to help them with, and get them to that point from a knowledge-based standpoint. Number two is to link the fact that your heart, your brain, and your legs are all tied together in terms of this circulatory deficiency. So what affects one affects all. That's why diabetes is a CAD equivalent. It's a PAD equivalent. We need to make sure that if these patients are being treated for peripheral arterial disease, don't forget to make sure that their heart is okay, and make sure that they don't have any circulatory deficiencies in other vascular beds, because that stroke they might have had might be due to, unchecked peripheral arterial disease or unknown coronary artery disease, and making sure that their medical therapies are in place. And lastly, is to make sure that they get their regular checks with their eye exams and their foot exams, and also to make sure that their kidneys are okay, because ultimately that is something that will cost our medical healthcare system significant costs. If you look at the rates of heart failure, diabetes, amputation rates, blindness, dialysis rates in this country, we're going to be insolvent in terms of our healthcare, in terms of our hospital trust fund and the deficit in the next 10 to 15 years. So what affects one affects all. And so they need to know that all these are tied in when they're being diagnosed with either one or multiple of these conditions.
And I think a question that the patient needs to ask Chris in your scenario is, what's changed over the last year, doctor? Their notes should be able to say that, their pulses were diminished in 2021. What do they look like in 2022? There was no redness in their foot in 2021, and they're noticing some red areas here. They're noticing edema that wasn't there, swelling within the feet from last year. What has changed in my body from the last time that I saw you, doctor? And that should lead to a conversation to all the things that my colleagues are talking about. So I think that conversation starts with that yes, you as the patient should be noticing changes, but the doctor should be able to mention changes that they recorded in the previous year in their chart that, again, can be helping to catch things early.
Sure. Now, I know we're almost at time, so I would love to end with a message of hope and some optimism. And so, you three took time out of your day to be with us today and share with the many people who are watching this live and the many others that will watch this on record. So tell me, Feluso, Sarah, David, what gives you hope? What's the opportunity here? And why are you so passionate about the work that's going on here?
Yeah, what gives me hope is that, we live in a society where, when some people see despair, other people see hope. And, I always tell people it's an opportunity, it's a chisel to create, opportunity tomorrow where you can, be able to decrease amputation rates. If you put together a strong team, a compassionate team, continue to engage your community and talk about not only the technical competence that exists around where they're colleagues, but allyship and collaboration, not only locally, but nationally. That's what we've done. I've worked with everyone on this panel, and kudos to the ADA for doing this. But, we've come a long way in terms of awareness. I don't think PAD has had the awareness it's had this past year or two compared to other decades. I mean, I think that's hope. I think the fact that we're having this conversation, we've also hit the walls of policy in Washington, D.C., where now there's a PAD caucus. I think that's hope. The fact that policy hopefully will come out that will address social determinants of health, that's hope. And the fact that we continue to have these young doctors and nurses and techs in the pipeline who now work with us, who better understand what peripheral arterial disease and are willing to engage our communities and help us teach our community members. I'm hopeful that, over the next 5 to 10 years, that we'll be more aggressive, not only upstream, but downstream in addressing this epidemic that is preventable.
I would go with like that. I would say I'm hopeful for change. I'm hopeful for the future. Right now, we know where we need to go. We just need to get there. Patients all the time are are extremely excited and happy when they come in with a wound and it's gone and they don't have to get that amputation. So just keeping that progress going and the excitement towards how we can prevent this from happening for everybody, that is hopeful for me.
Thank you.
I think what's hopeful for me is two things. Number one, the technology that does exist nowadays. As I mentioned earlier, you weren't able to bring circulation down to a foot less than 10 years ago, and now you can. Amazing, absolutely amazing. The tools that I have available to me to close wounds that I certainly didn't learn when I was at medical school is unbelievable. But I also think that there's a really good noise happening. And the noise is people looking to make sure they get what they deserve for their care, they get what they need for their care, and for physicians making enough noise to say that their patients get what they need. So I do think people are advocating for themselves more. I do think the medical community, including ADA and medical organizations like this, are making enough noise that it can't be ignored anymore. So it's going to be a slow change to turn this train around. But I do think it's starting to head in the right direction. And I think that the tools are there. And to quote the statistic we've used several times, 85% preventable. That to me is tremendous hope, because as we shift people in to that 85% preventable status and truly prevent them, that's where the paradigm shift is really going to be.
Great. Well, I want to take this time to say thank you. Thank you for our distinguished panel. Thank you for those who are watching this live. Thank you for others who may watch this on record. I'd like to add another reason to give us hope, which is the fact that we're all here and we're all in this together. And I think being in this together and working together and collaborating, which is really the very essence of what the Amputation Prevention Alliance was created to do, is the way that we're going to get over the finish line. It's the way that we're going to reduce the tens of thousands of preventable diabetes related to amputations that take place every year. And I'm so thankful for the leadership of everybody on this panel here, as well as everyone across the country who has reached out to the ADA, who is partnering with the ADA on this. Some of the leading health advocacy organizations from across the country are partnering with the ADA to get this work done. We've talked about patient empowerment. We've talked about provider education. We've talked a little bit about policy change. Those are the calls that the ADA stands ready to answer. We stand ready to do the work on Capitol Hill to advance those needed policy solutions, including addressing the incomplete guidance that we're currently getting from the United States Preventive Services Task Force, as well as to make sure that access to services by podiatrists and access to services by other specialists are not put out of reach for too many patients. We know this is an issue that affects far too many unnecessarily, and more than that, affects far too many people just because of the color of their skin. And this to us is a tragedy, and one that we cannot afford to let go on any longer. So the ADA is proud to be leading in this effort. We're proud to have launched this important alliance. We look forward to ongoing collaboration with all of you on the panel here today, as well as all of you across the country. Share your stories, get involved, join us as we work to help people save their limbs, because it matters, because saving limbs saves lives, and because feet matter. So thank you, everyone. Thank you for being with us. We look forward to working with you going forward.
This was fabulous, Chris.
Thank you.
Thank you very much.
Thank you.
Pleasure to be with all of you.